Hello. Success. Yes. Yeah, good. I figured out how to button down there.
Oh, good. Good deal.
IT. Oh my goodness, this is long. Hello.
Thank you for bringing us food, Dr. Champion.
It's So feel free to grab some snacks. So full disclosure, I had a tea party yesterday for some women physicians. I had like 40 people at my house. I was like, first I was worried it was going to be too hot, and then I was worried it was going to be too windy, and anyway, now I worried that they didn't eat enough. So sorry if you guys are offended by leftovers, but I didn't want to throw them away. The vegan... the donuts are vegan, and then the small cupcake container is also vegan for those that are vegan. I think it's egg tarragon sandwiches, cucumber dill sandwiches, and then there's the other one is a chicken lingonberry from the Tea Terrace, which is like a place that's down on Rainbow. So unfortunately, this is a really long lecture. I should have brought coffee instead of snacks because you'll probably all crash at the halfway point. But the first half is more important physiologically. Now that I've had a chance to review the, I feel like it's too loud. Let me turn myself down. There we go. Is that better? Okay. The first half is more important for the physiology than the second half, which is more cases. And I realized I put way too much information into like the Cushing's case and stuff like that. So I'm going to skip over a lot of that because that is not what your exam nor step one is. It's more like physiology, understanding the physiology. Although I do think a couple of the clinical scenarios are really helpful to understand the physiology. So, and that's how I think as a clinician too. So, for example, if I think about like, okay, what do I see in adrenal insufficiency? And then I can work backwards and figure out how the renin, aldosterone, angiotensin system works. And I'm like, oh yeah, okay, so this will be high, this will be low. And there's a couple of things, the clinical things that are kind of like the prototypes for our for endocrinology for the like too much and too little. So the main disease states are 21-hydroxylase deficiency, Cushing's, adrenal insufficiency, both, and that includes both CAH and Addison's. And then obviously too much of aldosterone. So as you know those conditions, you'll kind of be able to work backwards from all the other things. If you're like, oh, there's some obscure stuff, of course, but that's not usually what's tested. It's the more common things. So a couple years ago, I used to be the Students for Rare Advisor, and we did it. I think I put the lecture in the slides in our files because it's kind of like interesting cases of like what we see, how this kind of applies to the real world. So I pulled our endocrinology Facebook group. There's like 4,000 of us in there now, and apparently pituitary is the favorite. And then thyroid, and I would have to say that mine is the adrenal, my favorite. I like the pancreas, but only the beta cells. The rest of it, Okay, so we're going to talk a little bit about sexual differentiation. But like I said before, the embryology is not covered until the next block, so this is all just very cursory. But I think it's helpful to kind of like just big picture look at it so that you understand what some of these conditions are. And the butterfly is the symbol for adrenal insufficiency. So like that's the blue butterfly is the kind of like their mascot. All right, so you guys are all way, 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 way better at this than all of my colleagues, but sex and gender are two different things. Sex is the biological sex assigned at birth, or sometimes called sex recorded at birth. Gender is your attitudes, feelings, and behaviors that are associated with it. So gender is a social construct and your social identity. And if you get confused, add the word identity and then it makes sense. So like gender identity versus sex doesn't make sense. So really like these big, gender reveal parties, they're not gender reveal. They're like genitalia reveals. So sometimes you'll see the words disorder of sexual development, and that is it's a little bit pejorative. Same as with ambiguous genitalia, you'll still see that a little bit in the textbooks. That's a little bit more socially acceptable, but really what we should be calling it is atypical genital appearance. And we'll talk a little bit about those. Some of these slides I stole from other lectures, and so the formatting's all a little bit weird. But so this was from one of my. I speak nationally and locally about gender affirming care. So when we talk about gender, you want to use the word cisgender or transgender. So cisgender is someone whose gender identity is congruent with their sex recorded at birth. But you have to say it's not the normal or the regular, because that's obviously not. There's a spectrum of normal. And transgender is those that their gender identity does not agree with their sex recorded at birth. But you do not need to have surgery. You don't have to have CME for hormones to be transgender. And then, of course, this has been around for millennia, that people don't fit into two nice little boxes. And that's, there's various different terms for that: genderqueer, two-spirit, gender nonconforming, agender. And then, of course, sexual orientation has to do with who you sleep with. That has nothing to do with gender identity. And so there's lots of different things there, too, which I'm sure will be covered more in the reproductive section, too. So gender-affirming care is basically this whole spectrum of transition-related care, and it's primary care. So I really encourage, there's only there's 30 million people in the United States with diabetes, 1.6 that identify as transgender, but there's only 4,000 endocrinologists in the whole U.S. So the gender endocrinologists should not be managing gender-affirming care. And just like the same thing with diabetes, a lot of times people go in and they're like, gosh, my ear really hurts. And it's like, oh, it's because you're transgender. Like, no. So people that that are transgender obviously have the same medical problems as everyone else, and they face a lot of discrimination and a lot of, being boxed into certain things. And so obviously mental health, medical care, social services should all be involved in this. And we have clear, well-established evidence-based standards of care. And if you guys are interested, there obviously is a gender-affirming care symposium next Tuesday. So after the exam, and at least I think that's what it is. They don't tell me when the actual exam is, but we'll talk a little bit about that and why. And I think even if you're not interested in this, it's good to have the exposure. And why the politics, I'm not allowed to talk about politics, but the politics are different from the medical perspective. And so knowing the medical parts can actually help you be a more informed clinician and decide what you choose to practice, how you want to practice going forward. So as far as sexual differentiation, back in the day, they realized that there was something on the Y chromosome that made XY babies have male genitalia, and they initially called it testis determining factor, and we now know it as the SRY gene. So these Leydig cells make testosterone. There's something called the Mullerian inhibitory factor, and it's made by the Sertoli cells. So without this, I always don't want to say you develop as a default female, but that's really what happens. So there's the genitalia starts as female, and you need these factors, this TDF, the SRY gene, in order to make the male genitalia. So you need some testosterone and specifically DHT to make the external male genitalia. And the ducts, mesonephric, Wolffian ducts, paramesonephric, and what they go into. So the Mullerian this always confused me, but they're the same thing. Anti-Mullerian hormone or Mullerian inhibitory factor are the same thing. They inhibit the growth of the paramesic duct, and then you need the androgen. So you could imagine that there's places where you might have one of these but not the other, and that might lead to atypical genital appearance. And we've known this for a long time. These are obviously from like the 1940s and the 1950s. But it's still kind of amazing that, we're not even 100 years later, and this is not that long ago that we figured out how a lot of this works. So there's still ongoing things that are happening. So the external genitalia forms early, week 6 to 9. And there's these 4 structures, and again, this is embryology, so this is next block. But and they go into so there's in the male these 4 things, and what they go into you need to know, but not for this. What you do need to know is that the DHT is required for differentiation, and that the 5-alpha reductase enzyme catalyzes this conversion of T to DHT, dihydrotestosterone. And then but you have a deficiency of that enzyme. You get labia and female genitalia without the 5-alpha reductase. So there are people that have this disease called 5-alpha reductase deficiency, or 5-alpha-R. So for the female, those 4 things go into these other 4 areas. And in order to have estrogen, have these, obviously the estrogen has to be higher than the androgen. And you could imagine if mama has a condition where she has higher testosterone than average, this may affect the baby's development as well, the fetus. So we're jumping ahead here, but I have 3 clinical scenarios. These are all people that I've seen in my clinic. This is a 32-year-old woman seen by endocrinology at the VA. She's a veteran for primary amenorrhea. She has 10 or 5 breast development and female-appearing external genitalia. GYN exam does not demonstrate a cervix. Her chromosomal analysis is XY, and she has chromatin-negative nuclei. So how's this possible? What would her lab show? So this is a little tricky, but this is androgen insensitivity syndrome. So she has XY. So when you see this, and MBME questions like to ask this chromatin negative nuclei. So that means bar bodies. You should have 2. If you have 2 X's, you should have 1 smashed up against the side, and you would have a bar body. But that means you're either X. So Turner's would have it. You only have 1 X. XY chromosomes would have it as well, but somebody who is XX should have chromatin positive nuclei in the cell. So that's another way of saying there's only 1 X chromosome. So this woman unfortunately found out that she had a blind vagina at age 32. So she only had the bottom third of the vagina develop, and she was XY. So she learned that at age 32. Here's another case I saw actually not that long ago. A 39-year-old man who was referred for hypogonadism, low testosterone. He was found to have gynecomastia by his primary care doctor. And he's been trying to conceive for many years. He and his partner have been unable to conceive. His testosterone was 180. FSH and LH are high. They're like 50. So that means the pituitary is screaming at the testes saying, "Oi, I want to see more testosterone here." And the testicular exam is notable for testes in this range here, 4 to 5 milliliters. Whereas puberty, adulthood is 20 to 25, even, 15 to 25 is kind of normal. So very small testes. We did a chromosomal analysis and found it was, he has XX. How does this happen? So he has high testosterone. Oh, and the last one I should say, she also had very high testosterone, like a testosterone in the thousands. But obviously her body can't use it. So in this case, what you need to make male genitalia is that Y gene. So there was a translocation of that SRY gene onto an X chromosome. So he has XX plus the SRY. So he is phenotypically male, small testes. Unfortunately, so I sent him to urology to see if they could do any advanced reproductive techniques with with extraction and things like that. But mostly we just treat with testosterone. And then we have a newborn. You'll see this actually not infrequently on your pediatric rotation. That is born with typical male genitalia, but the parents had amniocentesis that showed the fetus was XX. How is this possible? This is one of our common things in pediatric endocrinology. So XX But what you need is testosterone, or DHT, to make that external genitalia develop. So this baby has 21 hydroxylase deficiency, or congenital adrenal hyperplasia. And in babies, this is it's one of the more common reasons that we have adrenal insufficiency at birth. It's the CYP21A2 gene. So again, this is one of our prototype cases for. So they're born with, sometimes on the spectrum, depending on how much exposure, but they lack this enzyme in the body. And obviously it causes adrenal insufficiency. There's a spectrum, and I'll talk about it. It's actually the very last part of the lecture of adrenal insufficiency. But you would be if you were the neonatologist and you heard the story, you would be very concerned that the baby might have salt wasting adrenal insufficiency. And so you would be looking out for adrenal crisis and dehydration in the first days. So the politics of this is that, our politicians say, there's only two genders, male and female. And I think those last three cases, prove that that's not true, that we have a spectrum of humanity. And this is where the medicine meets the physiology. And I hope you guys all as physicians understand that what happens in the news isn't necessarily what is true in the science. So this was a ACP. We did a Hill Day 2 years ago, and this was Marjorie Taylor Greene's office, which is directly across the hall from Susie Lee's office, who's one of our representatives here. And I was like, wow, this is like a huge difference between like rainbow everything and her office. She was now since, but we went there. If you ever get an opportunity to go to a Hill Day for whatever your professional organization is, it's interesting because the people that work in even I didn't get to meet any of the representatives themselves there. You meet their staffers, but they're super savvy. They know their stuff, and so they can be really helpful resources. And unfortunately, physicians are kind of one of the worst organizations for organizing ourselves. And part of what I did yesterday with this whole tea party, why there's snacks here, was trying to get all of our physicians to be more politically active and to be more involved in advocating for ourselves. Like nurses are great at it. They have lobbies, they have unions. We as physicians are just we get so self-involved, and we don't get a chance to advocate for ourselves. And that makes a difference, and obviously in our reimbursement and our other things. So that is part of it too. Now this, you will probably have nightmares for in the rest of your life. But this is the adrenocortical hormone cascade. You do sort of need to know this. Not in huge detail, but basically that there are three pathways. There's the aldosterone, the cortisol, and the androgen. So mineralocorticoid, glucocorticoid, and androgen pathways. And I think it's helpful to learn it in this format. You can also learn it in the other, horizontal format too. Pick one, stick with it, and if somebody tries to show you the other one, just la 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 la, so that you can remember it in one direction. Okay, so talking a little bit about anatomy. The adrenal gland is tiny. It's 2 centimeters wide. It only weighs 4 grams. This is a cartoon drawing here of it, but it doesn't really look like that in the real world. But as we talk about with histology, the hormones are how much size that the cortex makes for each of these is actually represented in the thing. So 75% is the fasciculata, 15% glomerulosa, 10% cortex. It has a very, very, very vascular supply, blood supply, so arterial, and that's why it's one of the more common sites for metastasis. I think it's like the 4th most common place, and it's and obviously in internal medicine we need to know like which things metastasize to the adrenal glands, but it's also one of the areas that hemorrhages fairly frequently. So the blood supply, I think I might actually have this, this is important when we talk about doing a procedure, an IR procedure called adrenal vein sampling. So you need to know the anatomy and why one side is more difficult from the other. But when we talk about Conn syndrome, we'll add that. So again, I should have brought Fig Newtons today, because my kind of explanation is that it's the Fig Newton. So this is your cookie part on the outside is GFR, or salt, sugar, sex. Glomerulosa makes the mineralocorticoids, specifically aldosterone. That's your most common one, but 11-deoxycorticoid corticosterone E11-DOC also is a mineralocorticoid. Main one for fasciculata is cortisol, and of course DHEA, which is your androgen, comes from the reticularis. And then the FIG part is your epinephrine, norepinephrine, dopamine, your catecholamines. So I think the mnemonic, everybody knows, it goes, it gets sweeter as you go in. So you remember that salt is on the outside, salt, sugar, sex, in that order. And this is a very common picture to get, minus the nice little labels here, of recognizing that there's a capsule on one end, G, F, R, and then medulla, and knowing which one of these is which one. And, they could give you a question, something like, this guy has hypertension and low potassium. Which level does he have a tumor in? And you'd need to know, okay, that's kind of a two-step question. He has Conn syndrome because he's got hypertension and hypokalemia. So that's aldosterone. And which one's aldosterone? That's the glomerulosa. So you'd have to pick the glomerulosa. And these correlate clinically with what we're prescribing. So I have someone with adrenal insufficiency. Normally the adrenal gland makes 10 to 20 milligrams of cortisol a day, and I use hydrocortisone 15 to 25. And I'll tell you why it's not exactly the same, but later. And we sometimes replace DHEA, especially in women. DHEA is, and women have both DHEA and testosterone. Testosterone is made by mostly the ovary in women, but obviously in men, the testes make the biggest part of it. So DHEA is like tears in the ocean of the androgens that they need. So for women, it makes a big difference. So it's about 50-50. But if you had somebody who had hirsutism, you'd have to figure out, where's it coming from? Is it coming from the adrenal gland, DHEA, or is it coming from the ovary ovarian hyperthicosis, or maybe a tumor of the ovary? Okay, so adrenocortical hormones are what type of hormone? Steroid, peptide, or amine? This is low-hanging fruit. This is your classical steroid hormone. Should have brought y'all coffee. Jeez. So there are different. So steroids are, these are examples of steroid hormones. So progesterone, cortisol, deoxycorticosterone. These are your mineralocorticoids, DHEA, and obviously androstenedione. So these are, obviously you've got your cholesterol molecule, and then you add some stuff to it to make that. And I have no idea where I put this in here, but there's different types of other hormones too. And I think Dr. Azar talked about this on day one. So for cortisol, our sugar, zona fasciculata, you can see from the way that they bind, you got this corticosteroid, cortisol binds to this receptor, goes to the inside a target cell. It activates this receptor complex. It goes to the nucleus. It sends something to a promoter. Then there's this gene which changes mRNA to RNA to protein. So you think this is a fast process or a slow process? Slow. Yeah, this is a slow process. So this is not like thyroid hormone. We have an instant. Or epinephrine, where you have instant hormone effect. This is a much slower process. Just to torture you more with that graph with this here. It's like it's interspersed. So one of the main things to understand is the circadian rhythm of hormones. And that is for all, pretty much all of the hormones, but the classic one is cortisol. And this, if you can remember this makes a lot of sense. So your body makes cortisol while you're asleep. And it's basically zero. It should be zero when you go to bed. Let's say you go to bed at 11 o'clock. I know you're all med students and you probably don't, but 11 o'clock bedtime, 6 a.m. waking. It should, while you're asleep, it should spike to get you ready for the day so that your blood pressure's ready to go, everything's ready to go, the lights come on, and you're ready to hit the ground running. We have just decided because it's nice for people to do labs at 8 a.m., that's when we know when what the level should be. So a cortisol level should be like 5 to 15. First thing in the morning at 8 o'clock in the morning. But it actually peaks probably a little bit earlier than that. It's probably more like 6 a.m. depending on what your circadian rhythm is. And then over the day, it slowly wanes and it should be back to zero by bedtime. And then in the background, ACTH is pulsing. So it's a pulsatile hormone. We often don't measure ACTH. We can measure cortisol, but there's these short-term fluctuations related to the ACTH. But in general, highest point first thing in the morning, and then it drops as you go down. Fun fact. Someone did a study that checked the hormone, the AM cortisol levels of med students, fine arts students, and business students. Who do you think had the highest level? Yes, they did. And fine arts had the lowest. And the cortisol levels of the business students were somewhere in the middle. But basically that, yes, cortisol, it keeps us alive. You have to have it. But there's a whole bunch of stuff on TikTok now. Like, I don't know if you guys are, maybe it's just my TikTok because I'm an endocrinologist. It's like all like, you have, a fat face because you have cortisol. And like, well, no, it might be because we live in America and we all eat too much. But yeah, there's all this stuff about like detoxing from cortisol and how you shouldn't, stress yourself out. But our bodies are designed for this. We're designed to have high cortisol over time, but not to pathologic levels, which we'll talk about at the end. So again, with our pituitary hormones and your flat pig, so you've got your hypothalamus that secretes CRH or corticosterone releasing hormone, talks to the pituitary, would make ACTH, which talks to the adrenal glands, which make cortisol, that feeds back to both of those and can turn them off or on based on the thermostat. So if I gave someone steroids, what should happen to the pituitary? Up or down? Down, yes. So your body's like, whoa, I didn't give you that steroid. I'm not making it. Back off there. So your pituitary should back off. So fun fact, we do this. This is what we do called a dexamethasone suppression test clinically. And we use dexamethasone because it's the only steroid that it's not actually available. It doesn't show up on the blood test the next morning. Whereas if I gave someone hydrocortisone, I'd actually be just checking their levels, like I was checking vancomycin levels or something. So you can actually measure that in the blood. But dexamethasone, you can't. So I give 1 milligram of dexamethasone at 11 o'clock the night before the blood test, have them do labs at exactly 8 o'clock in the morning. And normally, like I said, it should be 5 to 15. But if you took dexamethasone the night before, body should be like, whoa, So it should be less than 1.8. So if it's higher than that, that might mean that the adrenal gland is doing something weird and it's not listening to the pituitary signal, that that somebody might have Cushing's. It's just a screening test, and again, I went into way too much detail about cortisol later, which I'm going to skip over because you don't need to know it for this level. It's more like that stuff you learn on the wards in internal medicine. But we can check a cortisol, and now we're getting a little fancy, and we even check a dexamethasone level to make sure that actually they didn't metabolize it super quickly or something, and we're not getting a false positive because they have like super liver. So your prototype glucocorticoid or your prototype steroid hormone is cortisol, and it does all this important stuff. It allows you to stay alive between dinner and breakfast the next morning, so it does gluconeogenesis, helps, it's anti-inflammatory, it suppresses your immune response from going overboard, it maintains your blood pressure. Some of the things don't seem like a great idea, but obviously bone is both building and breaking down at the same time. And so this is a suppression of bone formation and increases renal blood flow. So with all of those things, what would happen if you had too much gluconeogenesis? What would happen to your sugar? Up or down? Up, yes. So you would get diabetes. So that's one of the things that if you had too much cortisol, you can think of this as like Cushing's, or if we gave somebody a bunch of prednisone, you would get diabetes. So you would have somebody have hyperglycemia. Anti-inflammatory effect leads to less pain. It suppresses your immune system, so we use that clinically. If somebody has asthma, to just kind of decrease the swelling and decrease all of that. We use it in rheumatologic diseases. We use prednisone for everything. It can also cause hypertension in too much effect. It can, because it's inhibiting bone, it causes osteoporosis. And of course, it can cause insomnia as well, which, so you're messing up that circadian rhythm. And this is, if you can, I'm not going to spend too much time on this, but when you look at this, this person should remind you of what it looks like to have Cushing's, too much steroid hormone. And so you would get stretch marks. You guys saw that on Friday, the large purple striae. You get this moon face, the neck swells, you get supraclavicular fat pads. And then you get this dorsocervical fat pad. And I would like, some people call it a buffalo hump, but I want you to keep the name dorsocervical fat pad in your memory because that's what it's officially called, and patients don't like to be called a buffalo in the chart. So now that we have open access, they're like, she called me a buffalo. Think about the pathology, and then you can remind yourself of the physiology too. Clinically, steroids are super important, and I'm sure there's some pharmacology lecture where you're going to learn about the importance of steroids. But basically, glucocorticoids, they all have different half-lives. Some are really long-acting, so like for fetal lung maturation in utero, if we use beclomethasone, which is like super long-acting. Dexamethasone is super long-acting, and then we have mineralocorticoids, and the main one is fludrocortisone, so that's a clinical one. So I use hydrocortisone to treat adrenal insufficiency. Why not dexamethasone or betamethasone? If they're longer acting, wouldn't that be better? It has to do with the half-lives. So again, I'm trying to mimic the circadian rhythm. I'm trying to so with like insulin, we've gotten really good. Like I have an insulin pump, and my insulin can give me different doses throughout the day to try to mimic what I'm eating and so this is what we're trying to do with adrenal insufficiency too. If I gave somebody like a big dose of dexamethasone, they'd be up here. It would be like treating somebody only with Lantus, with like a long acting, and they've got like one flat dose throughout the whole day. And we don't want that. We want it to mimic this a lot more physiologically. So this guy, Professor Hindmarsh, who's out of the UK, he's like an expert in CAH. I actually have his book. This is the normal circadian rhythm, so it's kind of wacky, but so again, 0 at bedtime, and then it rises throughout the day. And here's classically what we're doing. We're giving people doses of steroid. This person, I don't know what they were doing, but they gave themselves a dose of steroid in the middle of the night, which is not ideal. But this is what we're trying to mimic. So we have 15 milligrams with breakfast, 10 milligrams at lunch, maybe 5 milligrams at dinner, and it wanes off. So we're trying to mimic this light blue line as it goes throughout the day. But you can see that there's points where we're overdosing them. We're giving them too much. That's not physiologic. And there's points where we're underdosing them and they feel like garbage. So it's not that physiologic. I do actually have a couple patients that I've used in the past where I've used insulin pumps, and I've tried to mimic this a little bit better. But that's kind of a specialized thing, and it's not FDA approved. But again, it's like rare. Adrenal insufficiency is something like 1 in a million or 4 cases per million. So there's not a lot of research happening on how to improve quality of life, unfortunately, for these patients. So 58-year-old male with easy bruising, insomnia, truncal obesity, and diabetes has difficult to control hypertension. He has a CT of the abdomen, which was done for other reasons, which is negative. What is the next best step? What would you do? Check an ACTH, check a metadephrine, check aldosterone, or call his pharmacy to check his medication refill history? So first of all, what does he have? What do you think the guy has from the vignette? Easy bruising, insomnia, truncal obesity, and diabetes. Cushing's? Yes. Okay. So where can you get Cushing's from? ACTH. Okay. So it could be his adrenal glands, but they kind of gave you a out of order sequence there. They're like already did a CT. So we're going to look for ACTH. So obviously when you have Cushing's, it can be coming from the adrenal gland, it can be coming from the pituitary, it can be coming from the hypothalamus, or it could be coming from something called ectopic. So it can be really challenging. In fact, I have somebody right now that I cannot figure out. I keep trying to send them out of state to someone smarter, but unfortunately their insurance won't let me, so I guess they're stuck with me. But we have a whole protocol on how to check for Cushing's, because if you start pan scanning and what we call the gropogram, where you're like just trying to do stuff, you're going to get a lot of incidental findings. So 5 to 12% of the population have adrenal incidentalomas, and another 12% have pituitary incidentalomas. So you could get really, sucked into the wrong thing if you're not following a stepwise process. So why not metanephrines? What would they give you in the vignette if it was metanephrines? If it was a FeO? What are symptoms of FeO? Hypertension, sweating, tachycardia, panic attacks. So they would give you that kind of history. If it was aldosterone, they would tell you hypokalemia, which we'll talk about in a second. And then obviously if it was exogenous steroids, they'd probably say I don't know, patient has gout or has some reason to be taking steroids, and which happens all the time actually. So we have a lot of patients clinically that I think every single one of my fellows has published a poster on people that had surreptitious use of prednisone. Often they go to Mexico and get like joint capsules, and it has dexamethasone in it. And they're like, yeah, these things, I feel great on these capsules. And it's like, yeah, we know, because it's actually dexamethasone. But they get Cushingoid, and they come in, and then unfortunately we have to wean them over a long period of time. So that's actually really common here. It was also common when I lived in Tucson as well. It's people who go across the border for things. So moving on to aldosterone from our zona glomerulosa. So think of salt when you think of aldosterone, and it also has a circadian rhythm, but it's also has kind of a backdoor. And so instead of ACTH, the regulation is potassium and the renin-aldosterone-angiotensin system. Have you guys done renal already? Yes. Okay. So this should make sense because you learned about RAS in renal. Glomerulosa, angiotensin 2 binds to angiotensin 1. That's coupled to the protein phospholipase C with the G protein. So that's the second messengers for the calcium and IP3. So renin, these are the things that stimulate it. So there's different ways to this. So you could have hypovolemia in the afferent arteriole. You could have low sodium in the distal collecting duct, or you could have direct innervation from the sympathetic nervous system. And I tried to find a better picture than this one. This is from like my textbook from like 20 years ago. But for some reason, I like how this one shows all of it together with the macula densa cells right here next to the afferent arteriole, and the renin being released from the juxtaglomerular cells. So for some reason, I guess that's maybe how I learned it, and so it makes more sense to me. But if you get that decreased renal perfusion, obviously your blood pressure is low, and so you want to raise your blood pressure so that our aldosterone is going to be secreted. And then this whole ACE thing is just, so yes, you need to know this. Hopefully they went over this during the renal block too. But it is important because aldosterone is a hormone, and it regulates salt as well. So it stimulates sodium resorption by the kidney, the distal collecting tubule. And high potassium causes the aldosterone secretion as well. So it causes kaliuresis, or potassium loss in the urine, to get rid of potassium. So somebody who has high potassium, your body should be getting rid of this with aldosterone. So you should have a high potassium. And the reason why there's a picture of an avocado there, it's actually one of the highest potassium containing foods. So this is obviously something we talk about a lot in nephrology. Oh, these are the foods you need to avoid. Everyone's like, oh, bananas. Bananas only have 400 milliequivalents of potassium. An avocado has 980. So avocados are the way to go if you need somebody to have something that's low carb and high potassium. For example, Lasix. Lasix makes you lose potassium. So we have to counsel a lot on foods that are high in potassium versus low in potassium based on what their levels look like. Strawberries are also high. Chard, veggies, things like that are also high in potassium. So the aldosterone causes sodium resorption, so that's going to make the water stay in the blood vessels, so the water follows the sodium. You have kaliuresis, and it secretes hydrogen into the urine, which decreases your pH. So by this, I think you can envision one of those questions on the boards that's something like, they love these ones where they have like potassium, sodium, pH. Up, down, arrow, arrow, and you're like, ugh. So if you can remember, potassium is going to be high or low with aldosterone. Low. Perfect. Yeah, so potassium should be low. Okay, so here's an example of another guy who was diagnosed with hypertension in his 20s, which is young. He's on 5 different blood pressure medications and potassium supplements. What would you think about in this case? Hypertension, hypokalemia. What's too much of? Aldosterone, so B. Again, this is, so the fact that they're taking potassium supplements makes you think that they obviously have low potassium, so they probably have an aldosterone secreting tumor. So the endocrine, there's something called essential hypertension, which just means like generic, like run of the mill. There's no other secondary cause of it. And basically, the Endocrine Society and a couple of smart people have decided that we should screen the whole population, anybody with hypertension, because about 20% of them have too much aldosterone. And we have good mineralocorticoid antagonizing agents, so we can even treat those like medically, and then we'll have a lot better chance of controlling their blood pressure. So for labs, you kind of think through these. You would have a suppressed renin, a high aldosterone, typically more than 15. I have a guy in clinic right now. I just checked his renin is 0. His aldosterone is 34. His potassium was 2.2. Bicarb is a metabolic alkalosis. And then the cortisol is either normal or just not elevated, but it could also be low because the body's like, well, we have plenty of blood pressure here. And so the body's actually suppressing the metanephrine, suppressing the other ways because because of the hypertension, the big picture is the blood pressure is high. So this agent that we use is called spironolactone. It's an aldosterone receptor antagonist that's used for heart failure. They use like 25 milligrams for it. However, it's a dirty blocker, meaning it also antagonizes testosterone, and therefore we can use it to block testosterone in trans women, so people who don't want high testosterone. It's also used in cis women for acne or for any like androgen related things. So if people complain of hirsutism or hair loss, androgenic alopecia is pretty common. We use spironolactone for that. So I use huge doses of it, like 200 milligrams a day, 100 milligrams BID, whereas it's like 25 to 50 for heart failure. So if you block the aldosterone, what do you think that does to your potassium? Up or down? Up. Yep, you're right. So that's the one thing we have to watch for. So I always check a level. Most people it doesn't matter because they're the rest of the body is like, we got this. We can there's other methods. But for example, somebody who only has one kidney, they might get hyperkalemic. So spironolactone, because it's blocking aldosterone, that potassium can go up. There's also an alternative called eplerenone. It's more specific. It doesn't have the whole dirty receptor thing, and so it doesn't cause the gynecomastia. So obviously, if you block testosterone, men can get gynecomastia, but it's also super expensive. So we don't use it as often. And there's a new mineralocorticoid receptor antagonist called phenerone that we're using a lot in kidney disease as well. All right, moving on to the third layer, our androgens, which makes DHEA. So this is our androgen layer here. Fun fact, you can buy a DHEA over the counter in the U.S. It's actually controlled in pretty much every other country other than the United States. Typical dose is 25 to 50 milligrams. But like I said, it would only be useful for women because for men supplementing DHEA wouldn't actually make much difference. I have sometimes men who've been Googling too much, and they're like, oh, I just need to take this. I have adrenal insufficiency, so all 3 layers of the cookie part are not working. So their DHEA is 0, and they're like, why can't I take DHEA? I'm like, you can, but it's not going to do it because your testosterone is still working. Your testosterone is probably 500, 300 to 800 is normal. They have no problem with testosterone, so it just wouldn't help them. But it actually is optional for women with Addison's as well. So that's basically, there's not a whole lot other than the fact that if you have somebody with ACTH dependent Cushing's, you can imagine that their androgens might be high too. So that if you were, have all of these extra layers, so they can get hirsutism as well. So the middle bit, is we talked about kind of already. You have when we talked about the adrenal tumors. This is the center bit. It makes the adrenal normally makes 20% norepi and 80% epi. And then there's this enzyme called PNMT, which catalyzes the conversion. It's, again, biosynthesized from one of the tyrosine precursors. And there's this, I don't know why I'm talking so much about dopamine. Dopamine is but dopamine doesn't raise your blood pressure as much. So, for example, I have a Theo patient who came in with back pain. He's young, he was like 30. And they did an MRI and found that he had 28 centimeter adrenal mass. And it was dopamine. It was a dopamine secreting Theo. And unfortunately, it was not surgically resectable, but he is, we sent him to the NIH where he's on a clinical trial using a chemotherapy agent, and he's doing great. So it's actually shrinking the tumor. But dopamine doesn't have the same amount of like hypertension. So there are patients, we talked about like head and neck ones that are clinically silent. So dopamine also doesn't seem to raise blood pressure as much as epinephrine and norepinephrine. But what, and I don't think this is useful for your boards at all because I'm going into way too much detail, but basically this enzyme is only found in the medulla. So the majority of epinephrine is adrenal. So if you have somebody that's making, you know where to look, basically. But again, I'm just going to skip over this. Catecholamines and metapnephrin, we talked about that last week. So you want to check metapnephrin because the half-life is longer. We talked about that already. We talked about that. Triad, sweating, tachycardia, headache. Majority of people don't actually follow the rule book. But you're going to have look at all of these symptoms. And again, not typical of FeO is the flushing because that is carcinoid. But also differential, remember how I said spells were a common reason for consult. This is your differential for spells. So it could be a whole bunch of things. So a lot of people kind of get stuck when they realize that the metapnephrines are negative, but there's a lot of other stuff that can do it. So what are some of the syndromes that include a FeO from last week? Name one. MEN. Okay, so the MEN2s, 2A and 2B, von Hippel-Lindau neurofibromatosis. So you might have, give you a description of bumpy lips for MEN2B. It might give you these neurofibromas, that NF1 gene. You might get a port wine stain that should make you think of Sturge-Weber. And these are all like multi. So you guys have done brain and behavior? No, that's next year. Okay, that's a fun one. But these are all, so ataxia and telangiectasia, tuberous sclerosis, these are all have neuro things too. Hemangiomas in the brain. And so these ones are kind of like, obviously they cross specialties. So there's different things. You'll have GI and all together. So we have, this was a woman I saw in Tucson. She came from the reservation, from the Pima Indian Reservation, and she had end-stage renal failure. She was on dialysis because of hypertension, difficult to control hypertension. She comes in with a non-ST elevation MI. CT done for who knows what reason shows a 4.2 centimeter adrenal mass, is incidentally noted and found to be a FeO. What blood pressure medication should you use? B, phenoxybenzamine. So that's your classic one. So like I said last week, it could be, you can actually use some of the other ones. You could use a calcium channel blocker, but you definitely would not want to use carvedilol. Lisinopril, probably second or third line after you've done the alpha blockade. So here's her levels. Her epinephrine was a little bit elevated, but really her norepinephrine is like through the roof. So 5,000. We couldn't do a 24-hour urine because she's anuric because of her end-stage renal failure. And then chromogranin is kind of like a non-specific neuroendocrine marker. So we use it for a lot of neuroendocrine tumors. But you can see it's like through the roof as well. Renin, aldosterone are low. Why? Because her blood pressure is like 200 over 100. Her body's like, so the stuff that can suppress itself should be. So the renin and aldosterone should be 0. So phenoxybenzamine, obviously this long-acting, non-selective alpha receptor, has an irreversible covalent bond with the adrenergic receptor, and it can cause reflex tachycardia. But again, study this one because it is the classic one. Okay, let's take a little break. I have a gazillion slides left, but let's come back at 10. And I'm going to skip over some of the clinical stuff. Hello. Oh, wait, turn off my microphone here. Well. All right, so the next part, or I hid my microphone in here. So the next part's clinical, which I know for you guys isn't super related compared to so it's mostly third year. But I think having a perspective on what we see, you can either, for those of you that like to think clinically and work backwards, you'll have a kind of a setup for that, but also kind of some of the vignettes you might see on step one or on your exams, for example. So here's our 58-year-old guy with hypertension. He had his initially diagnosed in his 20s. His blood pressure is becoming more difficult to control, but he's not had any hypokalemia. He's on these 5 blood pressure medications. His blood pressure is somewhere between 130 and 180. What's blood pressure supposed to be, by the way? 120 over 80? Is that what you've been told? So it's actually lower. That's what we're treating to. But if we look at native populations before they were introduced to the SAD, the Standard American Diet, their blood pressure was 90 to 110. So that's probably more physiologic. Now, when I have somebody who comes in with 140 or 180 over 80, I'm not trying to get them to 90 over 60 or they'll pass out. Their body has adjusted to higher levels. So we're treating to 120. But anything over 130 over 80 is hypertension. There's different stages, which cardiology. Anyway. So he has obesity. He weighs over 300 pounds. He has central adiposity. His renin is 1.5, aldosterone is 50 after being off of the spironolactone. CT shows a 1.8 centimeter adrenal nodule. It's been the same for 5 years. It has less than 10 Hounsfield units, so Hounsfield units are consistent with adrenal adenoma. And we did these lab, just to be extra clear, we did a 24-hour urine collection. Everything is normal. So what's the next step? What do you do now? What do you think he has first? Does he have Cushing's? Does he have too much testosterone? Does he have a FEO? I'm going to torture you all. It's aldosterone. Okay. Why didn't he get hypokalemia? Why wasn't he my first slide said that he had no documented hypokalemia. Why not? Hint, hint, medications. Look at his med list. Spironolactone, exactly, yeah. This is a leftover tea from the party yesterday. It was a no tea, iced tea. It's 80 degrees. I don't think anybody wants to drink hot tea. But yeah, so spironolactone. So that's so that's why he didn't get the hypokalemia. So this is also why we had to stop it for 6 weeks to really recheck it, because otherwise your spironolactone, your aldosterone would show up lower. You'd get a false low on spironolactone. And same thing with women. So sometimes I have women come in and say, like, I have hirsutism. They're taking spironolactone, and I have to stop it because their testosterone will be low. And I really want to know what it is off the medication to make sure they don't have like a testicular tumor. Let's hope not. That they don't have a ovarian tumor that's making too much testosterone. Okay. So next step, this is clinical, but basically for you future radiologists, there's always a few in every group. They do something called a adrenal vein sampling. So they feed a catheter either in through the wrist or in through the groin, and they go into the adrenal glands, into the adrenal veins, and then take we use cosentropin, and we stimulate in these different areas. So you infuse cosentropin, which is synthetic ACTH, and before and after, and then you take a sample from the adrenal gland, both the right and the left, and then you get these numbers. And again, you don't need to know this other than the fact that we do this because of how common an adrenal tumor is. You don't want to make sure like, oh look, it looks like a duck, it's probably a duck, and then you go and take out the wrong adrenal gland. So you need to have this right to left ratio, a gradient, to confirm aldosterone producing adenomas, APAs. So in this guy, this is what we did. And you can see that the ratio here, he has 2079, 500 on this side, but the ratio is 36 to 1.2. And we also did it here in the iliac. So we're kind of measuring where it's mixed together. And so we have a very clear right adrenal aldosterone producing adenoma. So yay, that's also the sign of his tumor. That means we can safely take it out and not take out the wrong one. So he had a laparoscopic right adrenalectomy. So we're bringing in our endocrine surgeons or our general surgeons, and we see him in clinic 10 days later. He's off his spironolactone, he's off his clonidine, and we've been able to have his carvedilol, but he's still on hydrochlorothiazide and lisinopril. So he's from 5 down to 2.5. But unfortunately, he's had 30 plus years of hypertension. He probably has really stiff arteries. So he probably is not going to be able to come off everything. So it would be in our best interest to diagnose this earlier. In fact, this whole adrenal vein sampling, the recommendation is if somebody is like 30 and below, we don't even have to go through this. You just take it out because that's likely where it's coming from. But in older folks, we want to be extra sure. So primary aldosteronism is called Kahn syndrome because it was diagnosed by this guy named Jerome Kahn at the Mayo Clinic, which is kind of like endocrine mecca, by the way. So when I was a fellow, we actually all took a trip to the Mayo Clinic and in Minneapolis, in Minnesota, and place is amazing. Have anybody been to the Mayo Clinic? This place is like beautiful. Like you walk in, there's a grand piano in the center. There's like Dale Chihuly glass sculptures in the waiting room, and like it's gorgeous. It's this, they have all these underground tunnels so that you don't have to go outside because it's horrible weather there. But they get a lot of it's a nonprofit, but they get a lot of money from Saudi Arabia, so they have the whole top floor. Like they have the people from like the sheiks and whatever come in and they donate all this money to the Mayo Clinic. So anyway, it's this amazing place. But Mayo was an adrenal surgeon, so Scott Mayo, who plays. So basically anything weird and endocrine, Mayo Clinic. So we always send them there. But unfortunately, during the pandemic, the fellows, they started doing it virtually, and now they don't get to go there. So anyway, but back in the day, all 200 endocrine fellows per year would go and meet in person at the Mayo Clinic. So this guy, Jerome Kahn, had this woman who had muscle spasms, temporary hypertension, and he couldn't figure out where it was coming from. So we kept her in the hospital for 7.5 months to figure out what was going on with her. I mean, we're lucky if we can keep somebody in overnight these days before the hospital admin's they don't meet inpatient diagnostic criteria. So this is kind of remarkable. But he figured out that she had a tumor in one of her adrenal glands that makes aldosterone. So there's more than just a mass. You could have a single mass. That's probably the most common. But unfortunately, it could be bilateral idiopathic hyperaldosterone. So let's say you put the catheter into both sides and it was equal. Well, you probably don't want to take it out because they're both equal. The other side's just going to take over. So that we would treat medically. There's also a couple of familial ones. But what they all have in common is they have hypokalemia. If they had a unilateral hyperplasia, we could take out that one, the side that's making more of it. Or it could be, rarely is it ectopic, so you don't really have to worry about that. So again, hyperaldo, you localize it. If it localizes, great, take it out. If it doesn't localize it, treat it medically. So then, weird one, 22-year-old female presents in late April with hypertension, low potassium, renin, and aldosterone, low aldosterone. What is the likely diagnosis? I'm going to tell you this one because it's licorice. So licorice, the glycyrrhizia root, is actually a type of mineralocorticoid. So real licorice, like European licorice, the salty stuff from Norway. The black jelly beans here in the U.S. usually don't have it, but if you get it at World Market, they actually do have some of this in there. So this basically, it looks like aldosterone. So your body is so you have low renin, low aldosterone. It looks like hyperaldo, but the aldo is low. This is classically around, I think I've seen 3 cases in my career, and it's usually around Easter because people eat jelly beans at Easter. And so it's the licorice that's causing it. And there was one case where we could not figure it out with the patient in the hospital. And then I walked in to do word rounds, and they had a bag of jelly beans on their bedside table. And I was like, what are you eating? I felt like house. like digging through their personal belongings. I was like, I see that. So sometimes we joke that we're the food police in the hospital because like doing inpatient diabetes and people get like turkey sandwiches at night. You know, the turkey sandwich fairy comes and visits. Now we're the licorice police too. All right, so mineralocorticoid excess is the kind of big group. So it could be from Conn syndrome. You get hypertension, low potassium, metabolic alkalosis. So again, visualize the little arrows, things happening. Maybe test yourself on those. Various different types of mineralocorticoids, but classically you get obviously the high aldosterone and low renin. And then obviously some of the CAHs, which are not the ones that you're going to be tested on. Those were, but fludrocortisone, that's what I was going to say. So it could be exogenous. So if somebody was taking fludrocortisone, you would get the same picture because your body doesn't know that it's not true aldosterone. So fludrocortisone is our mineralocorticoid, pharmacologic mineralocorticoid. And again, 11-deoxycorticosterone is also, I've never seen that, but in the real world, but it is a theoretical possibility if you had somebody that had low renin. So here is a kind of a typical picture. This is a real case, but not a real picture. No, I mean, it's someone's picture, obviously, but not the actual one that I saw. So somebody with acne, 35-year-old woman, mood swings, hair growth in places you don't want it. So we have actually something called the Fairman-Galway hair scoring scale where we show a picture of, say, like circle which one best matches. So obviously hair growth up the belly button, facial hair down the sides of the face, hair on the chest, around the nipples, thigh hair. So those are areas where they're more associated with androgen-dependent hair growth. So she usually circles and gives us a score of how much hair. Probably in some clinical setting, they actually evaluate it. But most people remove it. Most people wax or they come in and they've shaved or waxed, and so I don't have a really good idea of what their hair growth really looks like. And she's gained weight. She's gained 10 kilos over the last year. Back pain, weakness. So her vital signs are all normal except she has hypertension. She has truncal obesity. She has purple striae. She has thin arms and legs with muscle wasting on the arms and legs. And she has tenderness over L4 and L5, and she has glucose in the urine. So there's her picture. So what do you think she has? Cushing's, great. Okay, good. We all could recognize Cushing's. So all of this is consistent. So she has the striae from and she probably has osteoporosis and most likely has a back fracture from the. In fact, this case, she had picked up a file box out of her trunk. She leaned over to pick it up and felt her back crack, and she had fractured her back vertebrae. Goodness, word finding today. And then there are different clinical signs and symptoms that are more classic. So obviously obesity, dorsocervical fat pads, the dorsocervical supraclavicular fat pads, dorsocervical hump. They're not really that specific. They could be from anything. Hypokalemia, most people are going to have the hypokalemia in Cushing's as well, which has to do with how cortisol works. Bruising, facial redness, proximal myopathy, so wasting of both arms and legs. And that purple striae that you saw on Friday, that big thick one, not the white pale striae. So a lot of these things, obviously you can imagine, hypertension, not very specific. A lot of people have hypertension. There's many different causes. But the main differential for this poor woman is PCOS. So PCOS is the most common condition. In fact, I wrote a PBL for our fellows that had to do with this. And it was about, because 12% of women have polycystic ovary syndrome, and it presents very similar to this. But what our job as an endocrinologist is to figure out, is it truly a PCOS, which is a diagnosis of exclusion? I think that's the next block. Or is it Cushing's? Or is it 17-hydroxylase? Is it non-classic CAH? So we need to kind of be doing some testing to make sure. And a lot of times we're like, yeah, common is common, and we just diagnose this. But obviously it would be disastrous to miss a case of Cushing's, especially somebody that had a fracture. So again, circadian rhythm is in adults and children is very similar. Should be low at bedtime, high in the morning. So while you're asleep, it goes up on its own. So fun fact, if you have high cortisol first thing in the morning, when are you the most insulin sensitive versus insulin resistant? So insulin resistance, morning or evening? Morning. So all this garbage I just fed you right now is all terrible for you. So basically, you're going to have this high cortisol. So American breakfast foods like cereal, pancakes, waffles, cupcakes, toast, whatever we eat for breakfast, Pop-Tarts, that is the worst time to be eating carbs. So it's going to make, because of that underlying cortisol, we should be eating protein for breakfast and or just not eating breakfast because most of us don't have the need for that. But basically, for my diabetes patients, I'm really having to spend a lot of time counseling. And it's because of this physiology, because of our circadian rhythm, that you have high cortisol in the morning and to keep you alive, physiologic, but also, unfortunately, we're not going out and, digging post holes. I used to work in Nebraska, and I had some of the guys that worked there, and they were like, well, I eat a farmer breakfast, which is like bacon and eggs and toast and this massive breakfast. And they're like, but my family's been doing this for generations. How come you're telling me it's bad? I'm like, well, what do you do now? You drive around in a tractor and it's all done, from a machine. Whereas generationally, we've been doing it manually. And so our lifestyles have changed drastically over the last 100 years, but the physiology has not. The physiology of having high cortisol in the morning, you don't need as many calories as you used to. So to diagnose this, what should we test? What test would you order? How do we test for Cushing's? Okay. Yeah. So dexamethasone test is a classic one, and this is the part I put way too much in here, but I'm going to skim through this because you do not need to know this. But basically, these are the three things that we use to test for. We do a dexamethasone suppression test. So if we give them dexamethasone, their cortisol should be what in the morning? High or low? Low, yes, thank you. So low in the morning. We could also do a 24-hour urine collection for cortisol. You're supposed to do it twice. Again, give them a jug. You tell them to collect the urine for 24 hours. Normal's less than 50. Now, the problem with this one is it doesn't tell us where it's highest. So it's just a whole collection. So I don't know if it's highest in the morning or highest in the evening or what, it just gives you a whole lump of it. It's not very specific. And then, of course, we can take advantage of the fact that the circadian rhythm, and we could check a salivary cortisol. So this is one of the few times when salivary tests are actually clinically used. Like the functional medicine people are doing all these weird, like your saliva copper was low. And I'm like, okay, what does that mean? But saliva cortisol, and the reason for this is it's really hard to get a 11 p.m. or a midnight cortisol at the lab because most places don't have 24-hour labs, but we can get a saliva test. So we give them these little Q-tips, they chew them on at bedtime, and then we send them off to the lab. It takes about 5 days. So at midnight or at bedtime, let's say 11 o'clock, between 10 and midnight is your bedtime, what should that saliva cortisol be? Low. It should be 0, essentially, because it's so bedtime. So if it's not, that's one of the most specific findings of an abnormal circadian rhythm. Unless you're a course med student, and then, you guys don't have normal circadian rhythms anyway. Or probably surgeons or anybody that has works shift work. So 24-hour urine. Now, the problem with each of these tests, and this becomes very clinically relevant, not so much for your boards, but for us. Let's say, so remember how I said on the first day, binding proteins are really important. So for cortisol, the binding proteins are really important. So let's say you had nephrotic syndrome or you have CKD. Your 24-hour urine is probably not going to be the most accurate. Or let's say you're taking birth control pills, which estrogen increases your cortisol binding globulin, and so you're going to have more bound, and you're going to have like a high level. So you kind of have to, we have to figure out, okay, for this patient in front of me, which is the best screening test? Short answer is we usually do 1 milligram DST for the, but there's also problems, lots of false positives. So typically, again, it takes about a year to diagnose somebody with Cushing's, try to figure out where it is, especially if it's one of the more rare ones. And we have to look for things like nephrotic syndrome, liver disease, estrogen that might be affecting it. So this is the salivette That's a little Q-tippy thing that we send off for midnight salivary cortisol. DST, give here at 10 o'clock at night. It should be low in the morning. We should suppress them in the morning. So again, this is for my young lady that I presented the case. Her AM cortisol is 19, but she was on birth control. So normal's 5 to 15. So maybe not useful. But she did have high midnight salivary cortisol and a high 1 milligram dexamethasone suppression test. So this is all a bit sus, right? This is all kind of like looking like Cushing's. She has a 24-hour urine of 325, less than 50 is normal. So this is probably Cushing. So we have screened her and now decided we're now in the workup for this. She has high cortisol. What's the next step? Should we look at imaging? Should we do some labs? ACTH. So we need to know where is it coming from. So in the big screens we put Cushing's into two buckets, ACTH dependent and ACTH independent. So is the ACTH the problem or is cortisol the problem? Obviously cortisol is always the problem, but is it coming from the adrenal gland, is coming from somewhere else? So ACTH dependent is the ACTH is causing the adrenal gland to make it, or ACTH independent is usually the adrenal gland itself. So classically an adenoma, or unfortunately it could be a carcinoma too, that's super rare. There's also some other causes, but basically if you had an adrenal tumor that was making cortisol, your cortisol would be high, and your ACTH would be high or low? High, low. Low, yes, because there's nothing wrong with the pituitary. It's feeding back normally, and the pituitary is like, oh, I'm not doing that. That's all you, adrenal. So the adrenal gland is it's autonomously functioning, so autonomous nodule. So you'd have low ACTH. Now, on the other hand, you could have a problem with the pituitary or the hypothalamus itself. So that's what we call ACTH. And this is the case I'm working up right now. I cannot find it. I know it's coming from somewhere. She doesn't have a pituitary tumor. She doesn't have, she does have an adrenal tumor, but that's a different story. But doesn't have like a classic others location is the lung. So classically this small cell carcinoma is the most common. She doesn't have that. Could be bronchial carcinoid. She doesn't have any of these other reasons where it would be coming from. I actually think it's a PNET or pancreas neuroendocrine tumor, but that's, so trying to find it can be a problem for us. But the majority, so especially in young women, it's pituitary. ACTH, but we have to figure that out. So ACTH would be high and cortisol is high. So that's how we know it's coming from the pituitary. Okay, so we have a 35-year-old woman with type 2 diabetes. She's on metformin. She's now on max dose glipizide and pioglitazone. She's following lifestyle advice. She's doing everything she's told. She has thin arms and legs, pendulous breasts, and truncal obesity. Her A1C is 8.9, which is not ideal. What would you check next? A, B, C, D, E. I wish nobody makes eye contact. So, what do you think she has? Is that adrenal lecture? It's Cushing's. Yes. So the key is she's got diabetes. So that's one of the side effects of, she's young too. Obviously, you could have type 2 diabetes at 35, but she's doing everything she's told, and she has some clinical features that are consistent with Cushing's. So which of those tests test for Cushing's? D, yes. Okay, what is 1A testing for? Acromegaly. So insulin IGF-1 is acromegaly. B, Hashimoto's. C, why would you check an insulin level? So you could check it for insulinoma, maybe, if you were looking for so somebody who had hypoglycemia with high insulin levels, that would be confirming. So you could also check it for insulin resistance, but that's not very useful. We can usually look at people and say, you have insulin resistance. I don't need to do a lab test for that because they'd have like acanthosis nigricans, they'd have central adiposity, tend to have overweight or have obesity. And ultrasound of the ovaries, why would you do that? So if you thought somebody had an adrenal tumor, an ovarian tumor, specifically hyperthacosis, so somebody who had a woman with high testosterone but low DHEAS. So the adrenal glands are like, it's got to be come from somewhere. It's probably the ovaries. So yes, the answer for this woman is 24-hour urine collection for cortisol. All right, 53-year-old woman for Cushing's, 24-hour urine is 4 times the upper limit of normal twice. ACTH is in the normal range. Cortisol doesn't suppress on an 8 milligram, so a high-dose dexamethasone suppression test. And they have a 6-millimeter pituitary tumor on MRI. What do we do next? This is actually kind of a hard question. So this is, so the 8 milligram is what's called a high dose, and this is probably more than you need to know, but this is most consistent with ectopic, and my kind of mnemonic or joke is that pituitary, so cancer, ectopic, ACTH, cancer doesn't care if you eat kale. Cancer doesn't care about ACTH. It doesn't care about anything. You do not suppress if you have an ACTH dependent tumor. It does not respond to anything. So even this high pituitary should suppress with a high dose dexamethasone suppression test. We know it's ACTH dependent, and you're like, why? The ACTH is mid-normal, but it should be 0, right? So if your cortisol is high, that's so basically we know that it's even though it's normal, it's inappropriately normal. So it's pituitary dependent, it's ACTH dependent. So we think it's a ectopic. So basically we would do some imaging of the chest, abdomen, and pelvis. All right, so moving on. We have a 28-year-old woman with type 1 diabetes. She has worsening fatigue over the last year. 2 years ago, her A1C was 9. Now it's 6.2. She doesn't feel like she really changed anything. She has lost a little bit of weight, but she knows she doesn't have to shave her underarms as frequently as before. She feels dizzy when she stands up, and she likes pickle juice. What does this sound like to you? This is a classic board vignette. And they always talk about pickle juice. What do you think she has? Okay. High adrenal or low adrenal? Low. Okay, so this is Addison's. And classically the vignette so Addison's, also known as autoimmune adrenalitis. Addison's is a autoimmune disease. So if you, just like in type 1 diabetes, your immune system attacks your beta cells that make insulin, rheumatoid arthritis, your synovial joints. Autoimmune diseases just get all confused and start attacking something. In this case, it's the adrenal gland. So it destroys all 3 layers of the adrenal gland. So your cortisol will be 0. Your aldosterone will be high or low? 0. DHEA, 0. 0, 0, 0. So you have nothing. You got nothing. Now, why does she want to drink pickle juice? Because she's a hypotensive. She's got no aldosterone. So what's her potassium and sodium going to look like? So potassium, high. Sodium, low. So you have that picture, low sodium, high potassium because of that aldosterone, missing aldosterone. Here is a case I saw, this was a while ago, but so we have a picture here of low sodium, high-ish potassium. They'd actually already treated it. And for some reason, this guy's TSH was also high. But this is the cosentropin stim test. So we gave this person synthetic ACTH. It's like a kick in the pants. So you give them ACTH, and the adrenal gland should be like, yeah, let's do it. So at 30 minutes, it's supposed to go up, and 60 minutes, it should be greater than 18 for a positive or normal result. This person, his adrenal glands actually were not terrible here. So this is adrenal insufficiency. What was interesting about this case, it's actually, he had renal cell cancer, and he was on like warfarin or something, and his warfarin level was like 8, which is super high. And basically he hemorrhaged into both adrenal glands. And so this is called Waterhouse-Friderichsen syndrome. It's classically associated with what? Infectious disease. Yes, meningitis. So that meningococcal disease. So, but it can happen in anything. It's also associated with antiphospholipid syndrome. So sometimes it's presenting symptom of that. So hyponatremia, hyperkalemia is adrenal insufficiency until proven otherwise. So if you remember anything about the endocrine block, hyponatremia, hyperkalemia, that's Addison's and or adrenal insufficiency. Now, obviously, there's other things that can do this, but you want to prove it to yourself because you don't want to miss adrenal insufficiency. This is obviously an inappropriate stim test. This person has adrenal dysfunction. So we lump this into what we call PAI, or primary adrenal insufficiency, because it's the gland itself that's the problem. So in adults, it's classically Addison's, which is autoimmune adrenalitis. Sometimes has the antibody 21-hydroxylase antibody, which is confusing because it's also the enzyme for POI, primary ovarian insufficiency, or failure. But in kids, it's more common to be CAH, adrenal insufficiency. So that also is a type of PAI. So in adults, it's 70% Addison. You don't need to know this, but 70% Addison's, 30% CAH, and vice versa in children. I don't know where all the CAHers go, other than the fact that there's this big spectrum of them. And so some of them are like, we don't need any treatment. We don't need. And I just saw somebody like last week who had lost their insurance, was lost to follow-up, stopped their hydrocortisone, had been on it since a kid. And then they were like, I don't even know if I need it. I've been off the steroids for a year. And I was like, okay, well, you clearly don't have salt wasting because you would be dead. So my job was to figure out what they actually had. And so we're going to do all the tests. So in a boy, you would think about, so especially like a young boy, you would think about X-linked adrenal-like leukodystrophy, which has, in your test for that, is very long-chain fatty acids, hemorrhage, Waterhouse-Friderichsen. Classically, nationwide, worldwide, the most common cause of adrenal insufficiency is TB of the adrenal glands. And so when JFK was asked, do you have, they asked him something like, do you have adrenal insufficiency? And he was like, no, because he had Addison's, and he was saying that he was trying to say that I don't have TB, but this is back when, presidents could actually shield their medical information. But interestingly, during like the Bay of Pigs, which was like the human crisis, the doctors were giving him steroid injections like every 6 hours through the entire thing to keep him alive because he was under so much stress. So he had physicians that were doing stress dosing for him as somebody with Addison's as a president. I think that now everybody's up in everybody's business. I'm not sure that would be something people would be like, oh, I don't think they can handle it. Anyway, the other thing I would mention for the boards or for like vignettes is that this is classic like board stuff. You see somebody with a vignette that has an has an autoimmune condition, always like red flag, put your antennae up that this could be a second autoimmune thing. The majority of people only get one autoimmune condition, but unfortunately, you do have about a 5% risk of getting a second autoimmune condition. So when they give you that information, it's usually because they want you to pay attention that there might be a second one. So this is somebody with type 1, so autoimmune diabetes, and they are like, there's got these weird scenarios. You would think that this might be something autoimmune. So that was the key in that question. So what do you see in adrenal insufficiency, primary adrenal insufficiency? Any signs or symptoms? All right, I know you guys know this, but you're all shy today. So hyperpigment. So again, hyponatremia, hyperkalemia. Not sure if I mentioned that. Hyperpigmentation. So you get overall skin pigment hyperpigmentation. So again, remember ACTH, POMC, pro-opiomelanocortin C. That MSH is kind of that same pathway. So you're going to get hyperpigmentation, and that's classic when the ACTH is high. So that if you have secondary adrenal insufficiency where the pituitary is gone, is not making the hormone, would you get hyperpigmentation? No, correct. So again, this is a picture here of somebody with palmar crease hyperpigmentation compared to normal, and compared to normal skin. So again, I mentioned buccal hyperpigmentation. This is one of the first areas where you'll see it. And the classic test for Addison's or for adrenal insufficiency is the concentropin stimulation test. So again, we give synthetic ACTH. what's the name of it? Act. Anyway, there's another brand name that you might hear too, but it's classically called cosentropin or ACTH. So you give it, and it should be. You can do it any time of the day and night. So if you have adrenal insufficiency in the ICU, you can do it. You can do this test anytime. So you don't have to do this circadian rhythm business because it should always respond. This is all clinical stuff, but if it doesn't respond, so let's say your cortisol is 0, and then after the cosentropin it's still 0, where's the problem? Pituitary, adrenal. Adrenal. So the adrenal did not respond. So the pituitary may be doing its job. So we could actually check an ACTH level. This is like an old slide, but I really like how it kind of shows that adrenal insufficiency is a slow process. It takes about 5 to 10 years. So classically, in the beginning, to get functional or like adrenal insufficiency where people are having adrenal crises, you need to be down here at 10% or less of adrenal mass that is still functional. So it takes years to get that. So in the beginning, we can check 21-hydroxylase antibodies. Eventually, you'll start getting a high renin, and then eventually high ACTH, and then they start having a suppressed response. But it's a long time. So the average person with adrenal insufficiency has visited like 5 doctors before they actually get a diagnosis. Now, switching to secondary, this is actually much, much more common than primary adrenal insufficiency. And we're going to lump them into pituitary and hypothalamic. So technically, pituitary would be secondary, SAI, and tertiary would be hypothalamic, but we really can't tell the difference between them because it's coming from up here somewhere. So something in the whole like thermostat part or the is what's causing it, and so we just lump them all together. So fun fact, steroids actually cause tertiary, but we always say it's secondary adrenal insufficiency. So if you had a pituitary adenoma, we have to look, is it making too many hormones? So we check our flat pig plus the target, so we do LH, FSH, and testosterone. We do TSH and free T4. But it could also be compressing. So if you had a mass and it was squishing the pituitary, it might be insufficient. So you might get adrenal insufficiency because you have a craniopharyngioma or something, big. And then the new one is the checkpoint inhibitors like pembrolizumab, the CTLA-4s. They can cause autoimmune hypophysitis, and they can cause adrenal insufficiency. Other ones, classic woman who loses a lot of blood during delivery and then has hypotension. That's called Sheehan syndrome. And fun fact, I just diagnosed, my fellow and I, we had a poster at one of the sessions. We had somebody who presented 25 years. Her kid was 25 years old, and she had partial hypopituitarism from her childbirth. And she had not been diagnosed before. So it actually can present quite late. The one that obviously is, she'd always had like low blood pressure. She never had a period. She was never able to breastfeed after her delivery. And we went back and realized that her labs, and somebody actually had worked it up before, but she didn't follow it up. So we actually, she felt a lot better after she was started on therapy. But so people can survive like amazingly for years without diagnosis. So again, whenever you're checking pituitary, you want to make sure you check the flat pig plus the target hormone, because let's say you check a TSH. Okay, TSH is normal. What does that mean? But it's really the free T4. If the free T4 is low and the TSH is normal, that's not right. The pituitary should be like, oi, do your job down there. I want to see more free T4. So you have to have both to know that where they're, that's why we always do them together. ACTH and cortisol, for TSH and free T4. Okay, so we're going to skip all this. In secondary, you get similar symptoms to the primary, but you're not going to get the electrolyte abnormalities. Why? So there's nothing wrong with aldosterone in this case. It's just the ACTH. So you still got your RAS angiotensin. So they're not going to have you're not going to have hyperkalemia. Sometimes you actually can get low sodium, so it's not a specific, but the potassium, that's specific. You're not going to get the loss of pituitary pubic hair because there's nothing wrong with that layer. It's just the ACTH that's deficient. So the adrenal gland is still functioning, but you just are missing those things. You're not going to get salt craving, hyperpigmentation, or orthostatic hypotension because your RAS system still works. Okay, so this is another real case of mine. 47-year-old woman seen in the emergency room, found to have very large adrenal glands on CT, massive, like we're talking 30 centimeters each. She was noted she was diagnosed with CAH at birth on her heel stick. And when I saw her in clinic, I actually met her mom, and the mom was like, yeah, she was treated all the way up through age 18, but then she was lost to follow-up when she was adult. She had atypical genital appearance. She underwent vaginoplasty and clitoridectomy at age 19 months. And she was started on steroids and fludrocortisone as a baby, and then she stopped all her medications, and here she is. So this is a CT of her adrenal glands. So these are her adrenals here. They're kind of big, huh? So it's massively enlarged. So this is what's called an adrenal myelolipoma. These are benign masses of the adrenal gland, but they are ACTH dependent. So basically, so what do you think this girl has? She was diagnosed on heel stick. Adrenal excess, or these are big old adrenals. Do you think her adrenals are working? Too much or too little? So we were replacing her hormones. So she has adrenal insufficiency. So this is, she had classic CAH, or 21-hydroxylase deficiency. So, however, even though she was diagnosed on heel stick, she actually had the middle one, the simple virilizing, which I think I'll show in a second. But basically, so she survived without these. So if somebody who was diagnosed as a baby with the salt wasting, they need that. They have basically no adrenal function. But because there's that continuum, she was in the middle, so she was able to get away with no replacement. But her pituitary was screaming at her poor old adrenal glands, saying, "Oi, do your job down there. I want to see more cortisol." And so her adrenal glands hypertrophied from all of the stimulation from the pituitary and caused these massive benign tumors. So we started on hydrocortisone and fludrocortisone, and we even tried dexamethasone with the hope that it would shrink these tumors because they were ACTH dependent. And we eventually got her labs back, and you can see she walked in the door like this. Cortisol's 2.8. This is low. Normal is like 5 to 15. So anything less than 3 in the morning, that's bad. Pituitary screaming at the adrenals, saying, "Oi, ACTH is high. Normal is 15 to 65. 17-hydroxyprogesterone is off the charts." So we know what this is. This is 21-hydroxylase deficiency. She also had high testosterone. Normal testosterone for a cis female is like less than 50. It was like 3 times higher. So this is the most common one, and this is the one you should learn about and that you should know. It's 21-hydroxylase deficiency and how it manifests. So unfortunately, we treated her for like a year, and it didn't shrink. And at this point, the adrenals were so large, they were actually squishing stuff. So it was squishing her inferior vena cava and her liver. And she actually had compression of the kidneys and the ureters, and she was getting hydronephrosis. So her body didn't like not having, so this was a mass effect. It wasn't the fact that she was adrenally insufficient, because we were treating that, but it was just the fact that the masses were so big, it was squishing all the other stuff in her abdomen. And she really looked like she was like 9 months pregnant. She had this really huge abdomen because these things were so big. So what would you do in this scenario? Future surgeons? Take it out. Take it out. Okay. So our surgeons took it out, and they were really, what was interesting about this case was that there was a med student who was on the service with us when we diagnosed it, and had seen the patient in our clinic, and then they were on the surgery service when it was resected, and then they saw her in ER later, and they were like continuous, so they were really interested to see the different stages of the process. So you can see these are really big. I mean, these were this size tumor, when normally the adrenal gland is 4 grams. So these are quite large. So this is kind of obviously a rare outcome of congenital adrenal hyperplasia. So this is one of the more common autosomal recessive disorders, and it's a group of diseases that have these enzymes. And the majority of it is 21-hydroxylase deficiency. I have never seen 11B or 3-beta. I do have a 17-alpha in my clinic, but the other ones, majority is 21-hydroxylase deficiency. So if you're going with odds, that's the one to pick. But also the one that is, if you understand this one, the other ones are more obscure. For PEDS and PEDS endo boards, you need to know all these other ones. It's the gene is important too. So CYP21A2 is the gene encoding for the 21-hydroxylase that causes this disease. So 75% have the salt wasting. So that's the really severe one that presents at childbirth. So again, and then the 25% of the simple virilizing, which is the one that this girl had. So she was diagnosed. She knew this from childhood, but just decided not to follow up. She was like, especially when kids with chronic diseases, unfortunately, they go through a phase. This happens with type 1 diabetes too, where they're so over-medicalized in childhood, and they're like, oh, you have to do your insulin, you have to do this. And then by the time they hit adulthood, they're like, I'm done. I'm not doing this anymore. Nobody can make me. I'm an adult. You can't, nobody can call Child Protective Services on me. So there's often this rebellious phase. She just let it be rebellious for 30 years. So, and then there's the non-classic form. We really don't know how many people have this because often people aren't diagnosed. They're often underdiagnosed with non-classic. It looks like PCOS, so they may be misdiagnosed with PCOS. There's some data from some populations, like Ashkenazi Jewish population. It's really not that much more common in that. It's just that we have better data on that population. But it is pretty common. It's something that we should be screening for, and it's easy. You just do a 21 hydroxyprogesterone level in the blood. So this is where the block would be. So as you can imagine, they get adrenal insufficiency. So they are a primary adrenal insufficiency. So they can't make cortisol, they can't make aldosterone, but they can make androgens. So that's why she had that really high level of testosterone. So she had, so you can have high DHEA and high testosterone. So it's actually fairly common. It's something you will see. I've obviously cut and pasted from this. So in this case, her ACTH has stimulated the adrenal glands, and she had, in childhood, in utero, she had those high levels. So she had the atypical genital appearance, and her parents had opted for surgery as a child. So sometimes it's required early, especially if there's they're unable to urinate, or they have a fusion of some of those areas. But now there's kind of a push, especially for the atypical genital appearance, to wait. And there's a couple books out, so in the space about really allowing kids with atypical genital appearance to live their lives, and then they figured out later as adults what their gender identity and how they want their genitals to look. Because most little kids, especially under the age of 5, they don't care what their genitalia looks like. Nobody else is going to see it. So they're often the parents would kind of push them in the years past to let's make it match their XY chromosomes. And then later in life, they're realizing, actually, you guys chose wrong. And they're having to undo some of that. So really, there's a kind of a push now to let, but it's really hard. If you're the neonatologist and you're the OBGYN and you delivered, you're like, congratulations. We don't know. The sex we're going to do is chromosomal analysis, and it takes like a week. And the parents are, kind of panicking, trying to figure out, what do I say? What do I say on the birth announcement? Okay, so we talked about this. So adrenal crisis. Signs and symptoms of adrenal crisis are vomiting, feeling terrible, hypotension, and it just looks like sepsis. It looks bad. But if a kid comes back 2 days after 2 days after birth with low sodium and high potassium, it's probably adrenal insufficiency until proven otherwise. So the other thing I mentioned to somebody in the questions was that for growth and development, you need cortisol. You need growth hormone. You need cortisol. So a kid with adrenal insufficiency, especially if it's let's say it's not treated, are they going to grow well? No. So the other thing we have to think of too is that growth hormone I don't know if Dr. Zora probably talked about this, in the pituitary electrode, growth hormone is secreted at night from bedtime. So while your cortisol is low, your growth hormone is high. And so you're doing all your growth at night. If we give a kid steroids, and this happens a lot, like if they have asthma and we're giving them pulse dose steroids to treat their disease, it actually suppresses their growth hormone, and it will prematurely fuse their epiphyseal plates, and it will cause growth reduction and short stature. So we have to be careful to try to mimic the circadian rhythm. We do not give any steroids at bedtime, one, because your steroids should be 0 at bedtime, but also because in kids it can really negatively affect their growth. So that's another reason why we always use hydrocortisone and not Pred or Dex. So why did I give the lady with CAH Dex? Well, she's done growing. We don't have to worry about that. And we were trying to supraphysiologically treat her to try to decrease that ACTH so that it would stop causing the growth of those big old glands. Didn't work, but it was worth a shot. So this is one of the things that's tested on basically all 50 states for the heel stick, which you guys will talk about in reproduction. This is what she had, which is adrenal myelopoma. So a female newborn has enlarged clitoris, partially fused labia, and a single urogenital opening. Within 24 hours of birth, she develops dehydration and low blood pressure. What is it? I think this is like the last slide, so you guys are getting there. It's adrenal insufficiency, probably CAH, probably salt wasting. What would you expect on the labs? Sodium? Low. Potassium? High. Great. And hormone levels? Aldosterone? Low. Yeah, you guys got it. Okay. So I think last slide, yes. If you watch TikTok or Instagram Reels, you'll hear all this stuff about adrenal fatigue. You know that you need to I don't know, detox, buy my supplements, whatever they're selling. I don't know, but it's not a thing. So adrenal fatigue is a myth. The adrenal glands don't tire out unless you have adrenal insufficiency. Adrenal insufficiency is real, obviously, but we really are trying to fight back against some of the medical misinformation about the adrenal glands. You need them. You should love your adrenal glands. But like everything in endocrinology, too much is bad, too little is bad. You need to Goldilocks, have just the right amount. So you don't need to buy people supplements for this. We don't do salivary cortisol testing for adrenal insufficiency, only for excess. And they do these weird like saliva levels at 24 hours a day, which is not valid for this. So we use salivary cortisol only for Cushing screening. So this is what we call woo. It's not a real thing. It's usually the cell stuff. And there's unfortunately a lot of it. There's probably a lot of it from every field, but for the poor adrenal glands, they get the brunt of it. And thyroid gets a bit too. There's a lot of people like, oh, buy my... So that actually happened last week. There's some chiropractor on Facebook who has a $500 course on the thyroid. And she's selling some supplements, and she's like, oh, you need to check reverse T3 and T3 and reverse and total T4 and like I think there's 17 different thyroid labs. And every time someone's like, well, Dr. So-and-so said I need to, and I'm like, will this never go away? Because you don't. You really, you only need a couple of thyroid tests. All that other stuff is woo. It's not scientifically valid. So please join us next week for the Gender Affirming Care talk and learn a bit more about what it's like to provide hormones for patients. Questions? So I did not provide, so I put in the drive, I asked Izura, I guess they took away our review session this year, but I did put in the rare talk into the drive, and I put in the adrenal jeopardy talk into the files. And I also have a Family Feud style video game thing, which is like a review session, which is like, top 5 answers for, this and whatever. The macros weren't working on it. So I'll put that in there too, but you guys can just use it to review. But you kind of have to do it on, without the macros playing, unless you really want to hear the Family Feud music, because it wasn't showing up properly. So somebody can fix that. But anyway, just for review purposes. But feel free to email me too if you have questions. Any questions now? All right, well, good luck. hope to see you guys on an endocrine rotation. Come see us in 4th year. It's a very chill rotation, so you'll like it.